Hello, East Coast, West Coast, and to our international audience around the world. My name is Adrian, and on behalf of the ASMBS, the Bariatric Surgical Training Committee, and my co-moderators, I would like to welcome you to this edition of the Fellows Lecture Series. Joining me this morning is the brains behind the operation, Dr. Kunoor Jain-Spangler, and the West Coast session will be hosted by Dr. Julianne Lloyd and the chair of our committee, Dr. Matt Martin. So welcome to our returning programs and faculty, and most of all, welcome to our brand new bariatric surgery fellows. The goal is to bring the world of bariatric surgical education together for high quality didactics by content experts and over the course of the academic year to cover the major topics within the ASMBS Fellowship curriculum. Over the past academic year, we've enjoyed a growing number of participating programs, and we welcome your questions to ensure an interactive experience for our fellows and our faculty. This activity does satisfy the minimum cognitive didactic requirements for your ASMBS Certificate of Additional Training. And as a reminder, it is also available on the ASMBS Video Archives website, another great resource. And also simply by searching in your browser ASMBS Fellows Project, that's available without a login or password. As a reminder, please use the Q&A function of the Zoom app to enter your name, your institution, and questions. We will get to as many questions as possible, and there will be a separate Q&A session for the West Coast rebroadcast of this morning's lecture. Moving on to today's topics, a timely topic for the beginning of the academic year. We'll be covering the preoperative evaluation and care of the bariatric patient by Dr. Farah Husain, and also the postoperative and enhanced recovery protocols after bariatric surgery by Dr. Stacy Brethauer. I do want to acknowledge that we have two incredibly accomplished speakers this morning, and in the interest of time, I will cover some of the highlights of their careers in the introduction, but amongst many other accomplishments, Dr. Farah Husain is newly elected ASMBS representative to the executive committee of the society. Congratulations, Farah. She has also chaired the Diversity, Equity, and Inclusion Committee of our society, which has been paramount in importance in this very program in identifying qualified speakers to ensure diversity of the speakers. She's also Associate Professor of Surgery at Oregon Health Sciences University. And I also want to say thank you, Farah, for waking up at 4 a.m., well, before 4 a.m. on the West Coast to join us this morning. Our second speaker is Dr. Stacy Brethauer. Dr. Brethauer is past president of the ASMBS. He is a highly accomplished researcher and author in our field, including in the domain of enhanced recovery after bariatric surgery, where he has been the PI of a very large study, multi-center study implementing protocols for bariatric patients. He is also professor and the vice chair of quality and patient safety at The Ohio State University in Columbus, Ohio. Without further ado, we will begin with Dr. Husain's portion of the lecture. Farah, welcome and take it away.
Thank you, Adrian. That's going here. First, I'd like to thank you for the privilege of speaking today and joining so many accomplished speakers. It's an honor. Good morning, everybody. So I'm going to talk about preoperative considerations in bariatric surgery. And hopefully many of these things are not foreign to our fellows, and they're things they've seen in the past because a lot of them are consistent with what we have to do across the board in surgery. And I like to say thematic and what we really should do and care for most of our patients. So I do have some education consultant disclosures, but none of them will be involved today. So like everything in life, right? If you plan, prepare, and perform, it's going to make life easier and more straightforward. And I think we have the most important reason to do that. And the most important reason, obviously, is because of our patients. We have patients that can go on to become superstars in what they do, and they really are thriving to have these changes in life. And so our job is to try and make sure this can be as safe for them as possible. And overall, that they can then work with the tool and instrument we're giving them to have some new quality of life and really meaningful changes that go beyond just weight changes. And so the preoperative assessment is obviously that starting point. And I think most programs already have a pathway or protocols in place. But a lot of fellows now are also going out to new programs that are just starting and saying, well, how do I do this? And what do I do to start these programs to safely enact bariatric surgery within my facility? So again, this is a quick list, but you want to look at optimizing your patient from the medical side, nutritionally, psychologically. Think about prehab, smoking cessation, glycemic control, diets, and do you need to do those EGDs? But I think the most important thing is probably the last bullet on here, which is know your MBSA QIP accreditation requirements as well. Don't forget those and get familiar with them, because in your career, those are going to be very important things that help guide you as well, and things that should be included in your preoperative assessment. So medical optimization. Well, one of the kind of low-hanging fruits that we think about a lot of times is sleep apnea. So I started with sleep apnea. When you look at consensus panels that have met on the management of sleep apnea and bariatrics, most of them recommend using either the Stop Bang or Berlin questionnaire to screen for patients as to whether they need to have a sleep study. The vast majority of our patients may need to have a sleep study, and a good number of them have already had sleep studies. Why do you need to do this? Well, we should be treating moderate and severe sleep apnea, and usually that's qualified as an AHI greater than 15. And to do that, we will then decrease cardiopulmonary risk, respiratory failure, and mortality. And so it's very important to have optimized sleep apnea. Some patients cannot tolerate treatment for sleep apnea in the form of CPAP or BiPAP. And so I also find that partnering with your sleep study team and finding out if there are other options, wearing an oral device, mouthpiece, etc., that can at least help optimize them. But as we all know, there have been multiple meta-analysis and systemic reviews that have shown the importance of avoiding postoperative oxygen desaturations and preventing cardiac events and respiratory failure. So this is something that shouldn't ever be overlooked. The next thing is the cardiac assessment. Again, we know that bariatric surgery slows the progression of cardiovascular disease and can improve cardiac health. And long term, it will reduce major cardiovascular events. So cardiac assessment can be very important. I do use a functional assessment myself first to decide who to refer for cardiac assessment. So we oftentimes will ask, how much can a patient physically do up front? How far are they able to walk? Can they climb 2 flights of stairs? And then obviously cardiac risk factors. Do they have new edema, shortness of breath, at rest, dyspnea on exertion, etc. The pre-op risk assessment for cardiac risk factors can be done technically by a primary care physician as well, using something like the Revised Cardiac Risk Index. It also can be done by your cardiologists. Whether you send everyone for cardiac risk assessment or just select patients is going to be ultimately up to you. But I do recommend asking for a risk assessment or risk stratification rather than cardiac clearance. From what I hear from my cardiology colleagues, it is one of their irks that we're asking them to clear people for surgery, but rather it can't clear and tell you nothing bad will happen to someone's heart. They can tell you that they've got them as tuned up as possible. And I think that's a good way for us to think of it too, is just because you get a prescription that says patient is cleared for surgery means really nothing other than, hey, I'm giving you what you want to see. But what you want to really know is, are they optimized? Is their heart as good as it's going to get and ready to hopefully withhold the stress of surgery? All right. Cancer screening. A lot of us do highly recommend that people get screened for cancer prior to surgery and are up to date on their preventive screening. A small number of cancers are captured every year in our population, and we know that there's a higher risk of cancer in patients who struggle with obesity, particularly when we look at things like breast cancer and colon cancer. So we tend to stress that prevention and screening be up to date prior to bariatric surgery. And then estrogen therapy is one that comes up as a question quite frequently. So I added that to this slide because we know that VTEs after bariatric surgery are a big deal. They don't happen often. They're reported at less than about 0.5%, but they can be a major source of morbidity and mortality after surgery. And when you look at the use of the link between obesity as well as estrogen use, it's been reported to increase the risk by about 24-fold having the two together. And this increases also with hormone replacement therapy that is compounded by increasing with age. So as patients get older and on hormone replacement therapy, they too have much higher risk for VTE. So therefore, in the ASMBS recommendations, it's recommended that you hold 1 cycle of OCPs prior to surgery or 3 weeks of hormone replacement therapy prior to surgery. The nutrition side, I think this is probably our easiest one to understand, and that 50% of patients report some kind of maladaptive eating behavior prior to surgery. This can be binge eating, nighttime eating, or other maladaptive eating behaviors. So it's very important to capture these up front. There are multiple things that contribute to obesity. And we know about the poor nutrition, lack of physical activity, but a lot of our registered dietitians also will talk to patients about sleep disruption. We know sleep hygiene now is very important for weight loss. And so reviewing those things is important. Going over stressors, medications, things that increase the tendency towards obesity. There have been multiple studies that have shown the benefit of having dietitian visits, and this is registered dietitian visits, to optimize weight loss and as well as finding those micronutrient deficiencies ahead of time and treating them. So if you have things available that can include the anthropometric measures like body composition analysis and resting energy expenditure, that's great. Those aren't necessary, but some patients really like to see those things up front to understand how they might lose weight, where do they carry their weight, what does all of that mean together. But really, I think the most important thing that's been shown time and time again is that if you have dietitian visits up front, patients generally will have better post-operative protein intake and that they will have better weight loss. And again, RDs are, I think, one of the most integral parts of our program, and they should be really incorporated early and often because they can help optimize and identify some behaviors that we may sometimes miss when we're looking more at the medical side of patients and forget about these other factors that add to or contribute towards formation of obesity. Psychological optimization. Okay, often this is my war cry is that this is not a clear contraindication for most patients, but it's needed by all patients. We don't usually stop patients in their tracks because of their psychological evaluation. I consider this again an optimization. We know that if you have postoperative psychopathology, you have a higher tendency for poor weight loss, and particularly if it's been unaddressed or uncontrolled. There's a higher risk for higher length of stay, complications, and readmissions. And this increases with things like anxiety up to things like schizoaffective disorder, et cetera. So the whole realm of psychopathology can affect postoperative outcomes. Our population does seem to have an increased prevalence of mental health impairments across the board. And so they may also have cognitive factors that lead to issues that are going on, poor health literacy, and general cognitive deficits. And so all of those things can lead to worse recall of instructions and adherence to postoperative dietary regimens and attendance to follow-ups. So it's, again, very important to psychologically have them optimized and ideally have that carried through to after surgery. If that's not carried through and it's not addressed, we do know that there's increase of suicidal ideation and self-harm that's been published on after bariatric surgery. There's increased alcohol misuse and other drug misuse after these surgeries. And so it's not just on the pre-op side, but also establishing a relationship with psychology that can be carried on throughout their treatments. The psychologist, licensed social worker, et cetera, a person that's evaluating this can help assess and improve their functioning and adherence and support overall and have ongoing follow-up. And so it's really important. Now, history of substance abuse, in most of the publications, there's no defined time for abstinence from substance abuse. But again, important that the treatment has been completed up front and understanding there is a risk for postoperative abuse. So ongoing treatment, again, is very important. And then that they've addressed maladaptive eating or any eating disorders is very important as well. These can be old or new, and sometimes patients develop more maladaptive behaviors after surgery. So it's important for them to have that follow-up to identify those if they're developing new behaviors that are not favorable. Prehabilitation and pre-op frailty, I think, is a really hot topic across the board in surgery. And there's a lot of data now that shows the functional capacity we know can be reduced after surgery, but if you can improve it before surgery, that can help patients. It can, if they have low functional outcome, they can have increased M&Ms after surgery and increased readmissions, whereas improving those have been shown to decrease those readmissions and decrease the mortality and morbidity. So Many patients will do 4 to 12 weeks of multimodal prehabilitation. This has always been considered primarily physical therapy in the past, but it can be a combination of PT, OT, diet visits, exercise visits, and this can be done via telehealth, in person. And so prehab in the age of COVID and with telehealth can still be continued, and it can be done in the form of health exercises that are done on videos, use of pedometers, DVDs, and daily smartphone messaging. So these do, again, show lower complications and shorter length of stay in abdominal surgery and CT surgery. This has not been, I think, reproduced in a large bariatric study, but it has definitely been shown in most major abdominal surgeries. And we know cardiac rehab is one of the cores to cardiac surgery. Cardiopulmonary fitness and increasing that increases pulmonary function in those patients and reduces complications. And so I think we can likely translate to our world, that it will increase that pulmonary function and hopefully help them with their walking early after surgery, help our patients just feel like they're able to be more active immediately after surgery. Pulmonary rehab, simply using an incentive spirometer, doing some inspiratory training and coughing prior to surgery for 2 to 4 weeks had showed decreased pneumonia and length of stay. So even doing at-home therapy can be very helpful in prehabbing a patient to have a better outcome after surgery. Smoking cessation is really important in our world. This definitely has been published on in the bariatric literature. And Haskins Nisquith review looked at 36,000 nearly bariatric patients and found that those who did not stop smoking had increased morbidity and mortality after bariatric surgery. They had a risk of prolonged intubation, reintubation, sepsis, and length of stay. We know cigarette smoke is probably one of the worst things there is out there. It causes accelerated atherosclerosis, increased platelet aggregation, vasoconstriction, all things that we don't really like to see in our postoperative state of surgery and in our postoperative patients. So the Cochrane review recommends 4 to 8 weeks of cessation. And they did say that nicotine replacements are likely okay. Even with nicotine replacements, the complications were reduced by 60%. And it actually increased 1-year cessation rates. So when they compared it to a placebo, there was no increase in adverse events and no increase of complications. So using nicotine replacement might be a nice way to actually help get patients to stop smoking for a longer period of time. We can do serum cotinine tests on the day of surgery, prior to surgery, but these cotinine tests do stay positive for nicotine replacement. So that's important to know. And they take about 7 days of cessation to turn negative. So you want to let patients know about that and know about that yourself as well. And an important factor is that there is a high risk for smoking recidivism after surgery. The vast majority of patients return to smoking at 6 to 24 months post-op. So while we're doing this for the perioperative risk reduction, it is important to know that many will start to smoke again, and to keep that in mind as you're doing your planning for surgery. So marijuana use, this is something that's a little near and dear to my heart because my entire practice after I've gotten out of the Army has been in states where marijuana has been legal. So I threw in a slide about a study we did in Colorado looking at marijuana use, because I don't think any of us know what we're supposed to tell our patients about this. And I don't know that this tells you exactly, but hopefully it helps a little. When we looked at our patients in Colorado and looked at 90-day outcomes, we stratified by those patients that reported using marijuana and those that did not in a legal state where we felt like we'd have better reporting. And we found no impact on 90-day weight loss or in surgical site infection, 30-day readmissions, complications, or ED visits between our group that used marijuana and group that did not. Now, there was a higher post-operative opioid use observed in our marijuana users. So the idea that we thought they might be treating their pain with marijuana and therefore have lower opioid use did not pan out. Our limitations in our study were that we couldn't identify how much people were using, what types of and forms of marijuana they could be using. And there were some confounding variables, and our marijuana users were generally younger and healthier. And it was a short follow-up of only the 90 days after surgery in small numbers. But that gave us, initially in Colorado, the idea that we actually did not stop marijuana use. And in Oregon, I do the same. I don't stop marijuana use in general, although I do tell them that smoking marijuana is probably not all that different from smoking nicotine-based products. And so I do ask them to not smoke ahead of time. And the less of the THC that they can use, the better it is. So the industry here is very intricate and developed, and there are so many strains and so many different types of product they can use from the dispensaries that we really can get into a deep conversation about just this topic. The one thing about marijuana use, however, is that it has clearly been shown in many papers that with use of marijuana prior to surgery, there is a risk for disordered eating. So too much eating, eating to relieve withdrawal or increased tolerance of food or loss of control. And this is particularly with the THC element of marijuana. And so long-term, we do counsel patients that if you're using a lot of THC, you're going to be at risk for regaining weight or not losing weight as robustly potentially because of this increased tensions towards disordered eating. The studies have primarily been done in the world of psychology and psychiatry, so they don't include a lot of BMI data to show that weight gain or weight plateaus early, but it's just something we try to make sure our patients are aware of. Glycemic control, before I would have said, well, this is easy. Everyone has to have excellent glycemic control before surgery. I stole this visual abstract off of Dr. Ali Aminian, who all of us, I think, know that name very well. Something his group really recently published on. And they looked at the MBSA-QIP data from 17 and 18, looking at a large number of patients, nearly 25,000, looking at their hemoglobin A1C as their preoperative diabetes control surrogate, and all of the 5 major outcomes: serious complications, infections, length of stay, reops, and readmissions. And essentially what they found was that suboptimal preoperative diabetes control does not mean you have to delay metabolic surgery, as it's generally quite safe. And so while there was a slight increase in some of the infections, there overall weren't as many adverse effects as we used to think. Now, the background to this is that there's been a lot of reports in the past. When you look at some analysis on the left side of your screen, we had 468 patients in this study with A1Cs greater than 8%, and they had increased wound infections and acute renal failure after surgery. When they did multivariate analysis on that group following their univariate, they found only the mean post-op glucose levels remained predictive of complications. So perioperative optimization of glucose levels seemed to be more important than just preoperative. And in Rollins' study, when he looked at 342 diabetic patients who underwent bypass, he had no difference in complications when the A1C was over 7%. When we look at sleeve patients, looking at 1,700 plus sleeve patients with about a 6% complication rate, patients had the same length of stay and no change in that, with their preoperative A1C being higher or lower. The higher A1Cs over 7.3 were only associated with higher risk of readmission, which is still a ding, obviously, and an issue. But I think we are evolving a little bit in the way we look at the A1C, in that it is ideal to try and optimize this. And we do know that by optimizing, and if patients can control their A1C better up front, it may also be predictive of better diabetic control after surgery and potentially better remission. So it's still important to do. But for those patients that really have a struggle with it and have a hard time getting better control, I think it's not meant to be the thing that stops people from having surgery necessarily. It's important to recruit a team, have an endocrinologist involved, make sure they've optimized them as much as possible, but also being aware there are a lot of different determinants of health that make it challenging to treat diabetes and have access to some of the best medications out there. Some patients are simply only restricted to having 1 or 2 meds that they have access to. And so it can be very challenging for them to get good control of their diabetes. So don't use that necessarily as your stopping point, but work to get that A1C as well controlled as possible for that patient. Preoperative diets. So the really easy part to me are the insurance mandated preoperative diets. Do we need to do 3 months, 6 months, 1 year? No, we do not need to do that. ASMBS has a very nice updated position statement on insurance mandated preoperative weight loss requirements. Really not been shown to be any great benefit for making a patient have to lose weight prior to surgery over several months that's mandated by insurance. But when we look at short diets, like liver reduction diets, liver shrinking diets, etc., those short diets can be beneficial overall. And the first area they can be really beneficial is what we just talked about for diabetic control. When we look at these short-term diets for diabetic control, patients who were able to reduce their insulin use by half during a preoperative 14-day low-calorie diet had greater weight loss at 1 year after bypass, but they also had higher rates of diabetes remission. So these can be a little predictive of how diabetics might respond after surgery and be a predictor for you, but also potentially help them with their diabetes improvement. One thing I want fellows to know about is what is the difference between a very low calorie diet versus a low calorie diet. So a very low calorie diet is defined as having 400 to 800 kcals per day, and a low calorie diet is 800 to 1200 kcals per day. Most of the very low calorie diets have in the past been used, were really published commercialized diets, things like OptiFast and MetaFast, although there are ones that we've all created, I think, within our programs as well. And the low calorie diets are more of like the commercially available everyday diets or things we often offer. There is not a big difference between using VLCD versus LCD in these liver reduction diets. And there have been published papers, numerous of them on both the VLCDs and the LCDs before surgery. But generally speaking, most liver reduction diets range from 2 weeks to 12 weeks. And most of them stay more in the LCD range, less than 1200 calories a day, but they can drift down into the VLCD range. If you're using a very low calorie diet for a long term, so up to that 12 weeks, you should likely monitor labs and follow those patients a little more closely. But with these patients, and Dr. Edholm's group showed that there was a 15 to 30% decrease in liver volume with a liver shrinking diet. 80% of that decrease in their studies happened in the first 2 weeks of the diet. The post-op complication rate can really vary from study to study. Some show that patients had less post-operative complications, shorter length of stay if they did these. Others reported no reduction in liver volume and no change in complication rates. So that has been variable, but I think the majority of them show that there's at least some decrease in liver volume and better glucose control with many of these liver reduction diets. They may need to be tailored to your patients. Diabetic patients can sometimes have a lot of insulin changes that need to happen if they're on a strict liver reduction diet, especially if it goes into the VLCD area. So as you create these, you want to work with your dietitian as well and your diabetic educator potentially so that you can anticipate some of the changes that might happen in medications with liver reduction diets. And then EGDs for all, preoperatively, yes or no. So this debate seems like it goes on, and we hear about it at many of our meetings. So I put in a slide for and against it, and we'll let you guys draw your own conclusions. But when you look at preoperative EGD for all, and this study is out of Germany, they did endoscopy on 636 patients pre-op over a 6-year range. And they found what they considered a very significant number of pathologies. 22% had H. pylori gastritis, 22% had GERD with esophagitis, 95 cases of Barrett's requiring further treatment, and 3 esophageal adenocarcinomas. Now, you do have to think about your location and where you are when you're looking at these. We are unlikely to see a 22% H. pylori gastritis rate in the US. Other countries that may be higher, and it's really important to study and evaluate that. But this group's conclusion was that all patients should have a preoperative EGD because of the unknown abnormals that will then change your operative planning. And they will have a significant impact on your decision making regarding the most suitable bariatric procedure and the most appropriate follow-up. Our EGD against, then we look at Dr. Gomez's study. This is from the Mayo Clinic in Jacksonville several years ago. They looked at 232 patients pre-op from 2006 to 2013, and they found 143 abnormal findings. The most common abnormal finding were small hiatal hernias less than 4 centimeters. They also found esophagitis. They found a few gastric polyps and gastritis. In this series, only 8 patients had a positive H. pylori test, and 7 patients had a large hiatal hernia that was greater than 4 centimeters. They found no cancers, no tumor, no altered anatomy, but they did find 3 patients with gastric varices and 1 with Barrett's with low-grade dysplasia. So they had 4 changes to their surgical plan. And those patients, they were all over 55, and they all had reflux essentially prior to the surgery as well, or prior to the endoscopy. So they said, mandatory EGD for all may not be necessary, and it might be appropriate to use alternative screening options. When we look at the IFSO, or the International Federation for Obesity's position statement that they just released, they did a meta-analysis and looked at 63 studies with about 495 patients having abnormal findings. And again, the most common abnormal findings were gastritis and hiatal hernias. they found that about 0.2% of the findings led to cancellations of surgery. And so there were a wide variety of findings that were identified in these studies, but not that many altered surgical plan, although up to 16% in some studies were altering the surgical plan. So they found in their study or extrapolated that about 25% of asymptomatic patients will have abnormal EGD findings. But the pool of all the studies were very different, very heterogeneous, and there's no info on what happened after the EGD and the management plan, so it was a little difficult to complete conclusions or recommendations. But their recommendations were that you should potentially recommend all patients that are symptomatic pre-op should likely have a pre-op EGD. Consider it for all of your patients because up to 25% may have unexpected findings. So if possible, consider endoscopy on all your patients pre-op. Consider your population, your location, and your planned surgery. So if you're doing a Roux-en-Y gastric bypass or a 1 anastomosis gastric bypass and you live in a place with a higher incidence of gastric cancer, you likely should do endoscopies on all those patients. And then also consider the type of surgery you're planning. If you're doing a sleeve or a 1 anastomosis gastric bypass, we know those have some incidence of Barrett's esophagitis, bile reflux gastritis, et cetera. Those are reasonable patients to potentially do a preoperative endoscopy on. So, and then obviously there's post-op surveillance that will be talked about later likely. I think the big theme is if you can, ideally, try and do endoscopy on all your patients. I will tell you for us in Oregon, our insurances will not cover preoperative screening endoscopy in an asymptomatic patient. So for us, it's very hard. And I don't know why they want to do a peer-to-peer review on every patient I want to do a pre-op EGD on. So we have to be selective here. Prior to this, I had better insurance coverage in another state. We did preoperative EGD on everybody. So consider where you are too and try to make it so that this isn't a barrier to care for your patients. I do scope some people on the table right before surgery, and I've counseled them about both surgeries. And then they know we'll decide based on what our endoscopy findings are there. So that's kind of an extreme thing, but on occasion we do that for patients as well. So again, I think symptoms is low-hanging fruit. Anyone that's symptomatic and has reflux should definitely get an EGD prior to surgery. And if you have the ability to do them for all your patients, probably not a bad idea. So my conclusions are really more of the soft, touchy-feely conclusions rather than the hard science conclusions, which are just be thorough and be complete, right? We need to evaluate these patients because they're our patients and we want them to do their best. Really think about optimization and not clearance. Try to get out of the habit of asking people to clear someone for surgery, but really help you get the patient at the best place they can be for surgery. Get them walking, get them moving, get them stronger before you take them to the operation. Establish your protocols and procedures and make it something that's done for every single patient. What I've been surprised by sometimes is I'll see a patient that looks very walkie-talkie healthy in the clinic, and then they go for their prehab visit, and I find out they have very poor exercise tolerance actually, or they have very poor inspiratory effort. And those patients can be the surprise ones, right? They're those readmits or those length of stays you don't see coming. But if you can catch them ahead of time, they can hopefully be the ones that help make your post-operative care even easier. And remember that bariatric surgery is very safe if patients are properly optimized, right? We're operating on people who we're doing these surgeries in concert with liver transplants. We're operating on patients with LVADs. We're taking on very, very sick patients now, and we're doing these cases very safely. So I think pre-op optimization, although the topic may be a little dry and not the most glamorous in the world, it's probably our most important spot truly in getting our patients through the surgery is what we do and see preoperatively. So again, thank you to the ASMBS, Dr. Dan and Dr. Jain-Spangler for the privilege of speaking today. And I'm happy to answer your questions at the conclusion. Thank you.
Thank you, Farah. Excellent review, concise yet very comprehensive on what is a very large subject. So I'm sure our fellows appreciate that. We're going to move on to Dr. Stacy Brethauer's portion of the lecture, where he covers some of the postoperative pearls and also some of the enhanced recovery after bariatric surgery protocols. Stacy, you're up.
Great. Can you hear me okay?
Perfectly.
Okay. And you can see my screen, hopefully?
Absolutely.
Okay, we'll get going then. So thanks for the invitation to talk. We're gonna kind of pick up where Farah left off. Hold on, I don't know why it's deciding to jump ahead here. We're gonna pick up where Farah left off and talk really about kind of this perioperative care that picks up when the patient shows up for surgery. She really nicely covered the prehabilitation, so I'm not going to go over that. And really what we're talking about, and what should be talking about anyways, enhanced recovery kind of protocols. You may or may not be in an institution where they have enhanced recovery in your bariatric program, but undoubtedly there are protocols and pathways, and you need to look at those. And if they're not consistent with enhanced recovery, I really encourage you to start working with your faculty to get that stuff implemented, because it does make a difference. I don't have any relevant disclosures for this talk, so I'm going to just talk about some key principles of enhanced recovery and review the current literature for some of the bariatric surgery outcomes around enhanced recovery. And then Adrian had alluded to the national project that we did, and I'll show you some of the data from that. And then just give you a few tips on how you can help implement an enhanced recovery program. I'm going to try to go to my full view again here and see, hopefully my computer doesn't take off again. So the goals of an enhanced recovery pathway, really what we're talking about is evidence-based medicine. And we all struggle with kind of dealing with dogma and doing it because we always done it that way. And one of the things I really like about enhanced recovery is it really challenges those long-standing practices that really are not based in real evidence. And so by reducing variability, you can reduce not only cost, but you can improve, the value equation. And the things that we see the most in terms of bariatric surgery is really early ambulation, length of stay, and happier patients. And that's hard to measure, but I think it's true. So just to kind of cover some of the key principles of enhanced recovery, if you're not familiar, the basic underlying principle is to maintain normal homeostasis as much as possible throughout the perioperative period. So you try to get these patients into the operating room in as good of shape as you can, as Farah pointed out. Once they're there, excuse me, once they're there, you want to try to minimize the physiologic and the psychological stress on the patient. All those things have negative impacts on, those stress hormones have negative impacts on insulin resistance. Patients become more catabolic. And so anything we can do to educate the patients, reassure them, manage their pain and nausea and anxiety coming in is really important. Minimizing insulin resistance, of course, bringing patients in the physiologic fed state rather than a fasting state. We always, the old NPO after midnight was never founded in any evidence. And the ASA guidelines have for a long time said that clear liquids are fine within 2 hours of surgery. And yet most hospitals still, stick to that NPO after midnight. And this is one of those things you really have to really work on to change that culture. But bringing a patient in a physiologic fed state with a carbohydrate drink mitigates their catabolic state, mitigates their insulin resistance, and can have beneficial effects in terms of their postoperative management and glucose control postoperatively, which you just heard is very important. The carb loading can consist of a lot of different things. Ideally, it's complex carbohydrate drinks, and there's commercially available drinks you can buy, but they can be expensive. And if your program can't provide them to patients, drinking just sort of over the counter or commercially available carb drinks or sports drinks is good. It's not as good as some of these complex carbohydrate drinks, but it's still good. And the issue is, do we want to do this in patients with diabetes? I think there needs to be good studies done on this. There are anecdotal cases of patients coming in with super high glucoses where they get canceled or have to delay their surgery. But I think in general, if patients coming in pretty good control, in general, patients with diabetes should still get their carb drinks unless you're really having trouble controlling them preoperatively. And then fluid overloads, not a good thing physiologically. It can impact your integrity of your anastomoses, and result in ileus. And if fluid overloaded patients has been shown really have higher rates of complications, especially with bowel surgery. So we used to flood our patients with a ton of fluid in anticipation that they weren't going to be drinking very much. Of course, that didn't make any sense physiologically, but now we've gone to really judicious use of fluids in the operating room, letting patients come in hydrated because they're able to drink 2 hours prior to surgery. And then in the operating room and post-operatively, really managing your fluids based on, some physiologic parameters. Urine output is probably the main one, and their oral intake, of course. So the evidence really has emerged over the last decade in colorectal and orthopedic surgery, primarily in enhanced recovery. Some of the outcomes that are consistently shown in those specialties are decreased length of stay, reduced opioid use, fewer opioid-related adverse events, less ileus. And then if you start looking at cost, you can demonstrate cost reductions primarily through the decrease in length of stay and decreased readmissions. Fewer complications. It's a little tougher to show that in bariatric surgery because our complication rates are so low to begin with. But that's kind of that was kind of the landscape in enhanced recovery. And so, we wanted to bring this more into the mainstream with bariatric surgery. And we already talked about the some of the specific items for those major principles, and I won't go over the prehabilitation because Farah did an excellent job of that. But it's really important to get your patients in shape for surgery, and that's what I tell them. Don't come in, in bad shape and just waiting for the surgery before you start working out and eating right. So get in shape for it. And I think setting patient expectations is critical. If you tell a patient they're going to be in the hospital 3 or 4 days, that's how long they're going to be in the hospital. If you tell them they're going to be in overnight, maybe 2 nights, that's typically how long they're going to be in the hospital. So setting those expectations and then aligning your care to those expectations really can get the throughput, more consistent, and you'll have happier patients who are ready to get out of the hospital. And it takes some responsibility in their care in terms of getting out of the hospital and moving on to the home setting. We talked about the carb drinks. We usually will have patients drink one of their drinks the night before, and then the morning of surgery when they get up, and then they're allowed to drink clear liquids 2 hours prior to their arrival. It's technically 2 hours prior to surgery, but we tend to just say, stop drinking 2 hours prior to your scheduled arrival time. So if they show up and the prior case had been canceled, then they can get right in. They're not having to wait around. So that's just a practical issue. We start patients on anti-nausea medications when they show up, and we give them non-opioid analgesics when they show up. In our particular case, we put a scopolamine patch behind their ear. You give them Celebrex and Tylenol. There's lots of other sort of strategies for this. Gabapentin is used. Toradol is used intraoperatively, post-operatively for some of this multimodal pain management as well. So you can kind of pick how you want to do that, but we use Celebrex and Tylenol. Intraoperative is probably the hardest part to change because you're dealing with, the anesthesiologists are very, just like surgeons, they can be very dogmatic and they do things the way they've always done them or the way they were trained to do them. And this, managing that change is probably one of the more challenging things with enhanced recovery. So you really need to find a champion or two within anesthesia that can help you manage the change and drive the change to really decrease opioids in the operating room, certainly long-acting opioids. Lidocaine drips have been shown to be pretty effective, but they're fairly high maintenance, especially after the patient leaves the OR. But regional blocks, either done by anesthesia or by you in the operating room via tap block, are really helpful. And then really in your timeout and your sign in and timeout, make sure you talk about, fluid management, how long the case is going to be, the fact that you're not going to put a Foley in, and talk about their glucose control and their prophylaxis in your preoperative sign in and huddle, and then your timeout, because just mentioning those things will, prompt the anesthesiologist to key in on some of these key concepts for enhanced recovery that they otherwise may just not pay any attention to. And then again, there's some things that we struggle with in terms of change management, letting patients drink the night of surgery. And for a decade, I didn't do this, and it just made me nervous, and I'm not sure why. But patients are so much happier if you can let them, and they tend not to overdo it. They'll manage their own intake for the most part. If they feel like taking a sip, they'll take a sip. If they're not feeling up to it, they won't. But most patients are able to start sipping on some clear liquids the night of surgery. And if you think about it, there's no reason they shouldn't be able to do that. Your anastomosis is not going to fall apart because they had some sugar-free, Kool-Aid. Getting patients out of bed is really important too. We all know, we want to decrease the risk of VTEs. Early ambulation is probably one of the more important ways to do that. And so having your team on the floor really geared up to get these patients moving early. And one way to do that is to minimize your opioids usage, because patients are not going to be lying around feeling nauseated and sleepy. If you've minimized your opioid use, they'll be ready to get up, move around, and be much more comfortable. The multimodal pain management is probably one of the real cornerstones of enhanced recovery. We want to decrease opioid use for multiple reasons, obviously. But giving them preemptive analgesia in the pre-op area, giving them scheduled non-narcotic analgesics like Tylenol, Celebrex or Toradol, gabapentin. There's other things you can do, but doing it on a scheduled basis, not waiting for patients to be in a lot of pain. And then same with antiemetics. Schedule them. They get them whether they feel sick or not. And then there's things written for breakthrough pain, nausea and pain that can be used as needed. We used to use PCAs. Adrian will remember at the clinic, we used to give everybody PCAs, and they would lay around for 3 or 4 days feeling nauseated. And we'd have 2 or 3 opioid-related adverse events a year where patients would have to go to the ICU for respiratory failure from their PCA. So, it just didn't, looking back on it, it seems ridiculous now, but that's how we did things. That's how a lot of folks were doing things. And so you'll notice if you stop using, a lot of opioids, you'll notice a big difference in your practice. If you hadn't seen a lot of it in residency, hopefully you'll see it in your fellowship. The one thing we still really struggle with is that knee-jerk reaction to give patients a prescription for a bunch of opioids at discharge. We figure, well, it'll save us a phone call. It'll, keep them happy if they do have pain, and they won't have to call us. It doesn't, actually, none of that pans out. If patients are not using opioids in the hospital, they do not need to go home on an opioid prescription. If they're using a moderate or modest amount of opioids, they should get maybe 5 or 10 pills, if that, or a small amount of liquid. It's rare that you need to send somebody home with like 20 or 30, pills of oxycodone after what we do in bariatric surgery. It's extremely rare. So look at what they're using in the hospital and talk to them about whether they really feel like they need a prescription. And if they feel like they need one, give them one, tell them to fill it if they need to, and avoid this sort of, let's give everybody a prescription for a ton of opioids. If you really manage this, you will not get more phone calls, and you will not get burden your staff with more phone calls about pain management, because you've selected the patients who really are managing their pain without opioids to begin with. So the data is emerging more in bariatric surgery. I'll go through some of this kind of quickly, but we have always done a good job with pathway-driven medicine, but there was a ton of variation across the country. And there was some ERAS Society guidelines in Europe that were published back in 2016 that if you want to, you sort of look at a boilerplate kind of, evidence and protocol for implementing a program, it's a good place to start. But with MBS AQIP, that gives us a great platform to try to implement some of these quality improvement projects on a very large scale. And we have to consider, what are we really going to change? Our outcomes are great at baseline, very low major complication rates. Patients come in pretty optimized. And now 75% of the cases in the US are sleeves, which even lowers the complication rate and length of stay even more. So what are we trying to do? Well, the less variation you have in your care, you're going to see benefit from it. If it's patient satisfaction, that's important. We know that as part of the value equation. If it's decreased readmission or even a shorter length of stay, that has benefits. The current literature is, I'm just going to show you very high level stuff. There's 5 randomized trials, 12 observational studies, and these forest plots pretty much tell the story. Across the board, you're seeing a decrease in length of stay with enhanced recovery compared to sort of standard care. Post-op nausea and vomiting, when it was measured, was decreased with the enhanced recovery groups. Complications, it's pretty much a wash, which is a good thing. You may or may, with very low complication rates to begin with, you may not move the needle there, but you're not increasing complication rates by implementing some of these measures. And so I think that's still a positive message. If you look at just the randomized trials and take out all the other papers, the story is the same, basically. Less length of stay, less nausea, and they did not show an increase in readmissions. And I think that's pretty consistently been shown in the literature, that you don't have patients coming in for readmission just because you send them home sooner. They go home sooner because they feel ready to go home sooner. TAP blocks, there's a study looking at transversus abdominis plane blocks. If you don't do TAP blocks, learn how to do them, teach your attendings how to do them if they don't do them. It's really a valuable adjunct to your perioperative pain management. We all know the nerves, intercostal nerves run between the transversus abdominis and the internal oblique. They're not preperitoneal, so don't raise a blister or a wheal in the peritoneum when you make your TAP block. That sort of egg-looking lump, is that what you want to see? That's the right plane. So you want to see those oblique muscles stretching apart a little bit, but it should be above the transversus. So that's where the nerves lie. And you can easily do this with laparoscopic vision. You don't need an ultrasound. You don't need anesthesia or pain management to do this. And if you do a TAP block with at the beginning of your case with long-acting local analgesia, you'll see a difference in patients getting up and moving. And that's what this data has shown: lower pain scores, lower morphine requirements, and earlier time to ambulation. The MBS AQ projects, again, this is our national quality and accreditation program. We have done several national projects. This one we did was focused on implementing enhanced recovery in programs that were not using enhanced recovery. And we looked across the country and found programs who had long length of stay, and particularly long extended length of stay rates, meaning a large proportion of their patients were in the hospital over 4 days. And so we recruited ultimately 36 centers identified by being outliers in their data for extended length of stay. We looked at just the primary procedures, and we gave them about 6 months to implement this protocol and get everybody on board. They signed stakeholder agreements, and we invited about 80 centers, and we were able to get 36 who were all in for the study, and we were really impressed at how engaged they were. The data I'm going to show you is just a comparison of the Energy project during the active year of data collection compared to the calendar year prior to implementation. And these caterpillar plots are really nice because you can look at a specific outcome in the MBS AQIP and see where the outliers are. Those are statistically significant outliers to the right there. I'm not going to go through this because we just did, but the protocol elements of the Energy protocol were exactly what I just talked about, all those fundamental concepts of preoperative, intraoperative, and postoperative care. Getting people to stop using drains routinely, stop getting upper GIs, let them drink the night of surgery. Those were really challenges, and we did a lot of phone calls and talk people through that to let them know it's okay. Nothing bad's going to happen if you don't have a drain to fiddle with when you make rounds the next morning. We measured 26 different process measures, and it's important. This was probably overkill, but it was our first big study like this, so we wanted to collect a ton of data and look at adherence. So for every patient, this was an additional field in MBS AQIP that the clinical reviewer filled out that allowed us to see how adherent to these different measures the center was being. So we ended up with 9,100 patients. You can see the split between sleeve and bypass, about 60-40. And then we compared that to about 9,000 patients the year prior. And our primary endpoint was decreasing extended length of stay rates. And you can see the graph on the right. Things were already moving in the right direction, but the study really accelerated and maintained a significant reduction in those extended length of stay rates. So these are centers that had 10% of their patients were in the hospital over 4 days. And we got that down to about 4.5% of their patients staying in the hospital that long. So that's a big reduction that was certainly statistically significant. When we looked at centers that were invited but did not participate, you can see the red line there. They did slightly better over time, but the energy centers actually surpassed them around the time the study started, and then were able to maintain a significantly better rate of extended length of stay compared to those centers who were kind of doing it on their own or were not participating in the project. Average length of stay is already short. We know that. Started out 2.5 days, but we're able to get it down to less than 2 days, which was it clinically relevant? I don't know, but it's moving things in the right direction and getting patients out of the hospital a bit sooner. We did see an uptick in bleeding complications. Wasn't statistically significant, but I think this, what I would say here is be very careful about your timing of using anti-inflammatories and your VTE prophylaxis. We had several bleeding complications because patients were getting their pre-op, Lovenox or pre-op heparin. Then they would get their, their Toradol post-operatively, and then they would get a Lovenox shot later that night. We were just piling on with the anti-platelet agents, and we had a couple bleeding complications. So most of this was just looking at the data and figuring out what we were doing wrong in terms of timing. Really no increase in all-cause reoperation rates or readmission rates. They stayed down throughout the course of the study. Adherence was really high. Those 26 process measures, we had 80% adherence across 36 centers with all these patients, and that's pretty good for the study like this. And what that tells us is the majority of the centers were adhering to most of the protocol measures, and very few missing fields, 2 or 3% of missing fields in the data. And this is really the take-home slide. So what this tells you is there's not one thing that makes this work. The more you adhere to the bundle, the better outcomes you're going to have in terms of length of stay anyway. So those centers that had adhered to, the majority of these 26 process measures had decreased their extended length of stay rate down to 2.3%, where those that weren't doing it still had a 7% extended length of stay. And it's very sort of dose responsive in terms of the more things in that bundle you adhere to, the shorter your length of stay. So I think that's the take home from enhanced recovery. It's not one thing, it's the entirety of the protocol and adhering to it and measuring adherence to it that matters. We did look at some specific things that seem to be driving some of this change, and they're the things that you would have expected, managing pain and nausea and early ambulation. The opioid use was reduced quite a bit, and we had 25% of the patients who received no opioids after leaving the PACU, which was a big change for a lot of these centers, and I think a big win for the study. So the next study was B-STOP, and that's focused really specifically on opioid use. And I won't go into great detail here because the data, this is interim data. Tony Petrick ran this one, and I think they're just now locking out the data for final analysis, but he presented it at ASMBS, and he really is a spinoff of Energy and really focused on opioid prescribing. And so they had all these different process measures that were being measured and recorded. The things they were looking at really were morphine, equivalent doses as an inpatient at discharge and at post-discharge. And so, sorry, I got this stupid, got the recording going there for some reason. So ultimately what they found was of all those things that were sort of binary fields where did it improve or not, 8 of the 9 fields that they looked at improved. So they were seeing things trending in a very good direction across all phases of care with this study. And again, final results pending. The one thing that was really not moving that we really need to work on still, as I mentioned earlier, was they were actually prescribing more opioids at discharge than they had previously. So that's really something we need to focus on and not sending all these opioids out into the community. So if you want to set up a program or help set up a program, I think there's some key things you got to do. You got to make a case for it. You can't just put an order set in your EMR and expect things to happen. It really has to be a programmatic approach ideally with a program manager, and then key champions throughout the hospital, not just physicians, but administrators, operations, and all kinds, and nurses, of course, throughout the phases of care. Make the case that you're gonna maybe spend a little more money here in the OR with some medications, but you're gonna drive value because you're gonna decrease the length of stay and cost, and you're gonna decrease variability. And then how do you get buy-in from your partners? I mean, you got to show them the data, right? So if they're not willing to do it, you should start doing it. And you'll see within 6 months, you're going to see a difference in outcomes. And so if you can show them where the variation is with real reliable data, show them where the variation is with both in their practice and where the outcomes lie, and then show how that changes over time. They'll become believers, and they'll wonder why, your patients are going home a day or two earlier than theirs, and they'll get on board. You got to collect data, not just about collecting the outcomes, but you got to measure adherence. If you don't measure adherence, then you have no idea if you're actually doing enhanced recovery. It doesn't have to be 26 different process measures, but 5 or 6 key measures can help clue you in whether you're actually doing the things that you think you're doing. Hardwire all this stuff into your order sets and set pathways in your EMR, and make those outcomes and process measures that you want to look at easily available, because you can a lot of times export those automatically without having somebody having to pour over the charts. If you put them in the right place, in the right way, they're extractable and measurable very easily. Get service line and physician level reports. You want to give people feedback in terms of how they're doing with adherence, review these things at least quarterly, and then continue to improve and drive that change with data. So in summary, I don't know why this thing wants to keep playing my recording, but I'm going to jump out of my slideshow here. Sorry about that. In summary, there's a growing body of evidence to support, improved outcomes for enhanced recovery in bariatric surgery. These 2 national projects have been, I think, successful with positive outcomes and really demonstrated the value that enhanced recovery brings in our specialty. The primary benefits we're seeing so far: decreased length of stay and post-op nausea, earlier ambulation with the TAP blocks. And I think the national culture is moving more and more towards enhanced recovery within bariatric surgery and getting away from some of these long-standing practices that were not evidence-based. So I ran a little bit long, but Adrian, that wraps things up for me. And thanks again for the opportunity to present.
All right, thank you both so much. Those were fantastic talks. I think we do have a couple questions, and we are knowingly running over a little bit. This will be archived, so if anybody has to go, you can find it on the website later, but we are going to try and get through a couple questions here. Paul Chandler asked in the Q&A, in regards to perioperative VTE, can you speak about what chemical prophylaxis, who needs it, who needs extended after surgery use?
Ali Aminian, who was mentioned earlier, developed a calculator for the indication for extended prophylaxis. That was based on NSQIP data, not MBSA QIP data. So, take that for what it's worth. But there's a calculator. If you go to Cleveland Clinic, risk calculators, Google it, it'll pop up, and you put in 5 different measures or 5 different items, and it spits out a risk. And the way we managed that at the clinic was, if there was a risk was 0.2% or lower, we didn't send them home with anything. If it was 0.2 to, 0.4 to 0, nothing. 0.4 to 1%, they got 2 weeks. If it was over 1% risk on the calculator, they got a month. And doesn't have to be hard and fast, but it gave us structure, and so we were consistent about it, and we did the calculator on everybody. So we thought about it and made a decision of whether we're going to give them extended prophylaxis or not. But if you don't want to use the calculator, at least set some criteria in your program for high-risk patients, hypercoagulable state, prior VTE, immobile, and just have a checklist at their pre-op visit and order it then, so they have it when they go home from the hospital.
Thank you. Another question from Ed Chen, who's one of my fellows here at Duke. What do you feel about the perhaps extreme of ARAS and moving to outpatient to bariatric surgery?
Yeah, I don't see ERAS as applying necessarily to outpatient procedures. It really is a inpatient kind of model. Not that you can't apply all those same principles to ambulatory surgery, but that's a challenging topic to cover quickly. So I would just say, if you're going to do ambulatory bariatric surgery and it's being done, be super selective, have all the safety nets around the patients, have close, close ties with the transfer center and all those things that you need to do to protect the patients if they have an outcome problem. But I don't think enhanced recovery as a sort of soup to nuts kind of program really applies to ambulatory.
Sure. And then there was another question. Are there any studies showing these tactics applied to bariatric endoscopy, such as the endoscopic sleeve gastrectomies? And I'm assuming the answer is similar.
I haven't seen.
The answer is no studies, but as far as applicability, maybe a little bit different again.
Yeah, we know the endoscopic interventions create a lot of nausea. So, with the balloons, we would just really give them a ton of antiemetics up front and post-op. So I'm sure it's very similar. I don't do ESGs right now, but I'm sure it's very similar outcomes, and you have to be pretty proactive with your prophylaxis, but nothing in your enhanced recovery.
So just a couple of things. We use the calculator that you alluded to, Stacy, and we find it very useful. Strongly recommend that other institutions look at it also. And I very vividly remember an instant when we were at the clinic where a patient on patient control anesthesia went to respiratory failure overnight, and I had to come in for that. But as we fine tune these things, and certainly we fine tuned a lot of things since then with the help of the great work that you and other researchers have done. A question for both of you. We talk about minimizing the physiologic impact on these patients. Intraoperatively, we know our procedures are mostly minimally invasive, but physiologically they may be maximally invasive. Where do you like to keep your pneumoperitoneum at? We know some surgeons stay down as low as 12, some as high as 18. Farah, Stacy, can you both weigh in on this?
I don't adjust too terribly much. I usually leave it in the 12 to 15 range unless there's a reason I need to run lower pneumoperitoneum, which on occasion does happen. Conversely, if we have the patients with super obesity and we're looking at the over BMI 70 plus, then we oftentimes run them higher at 20. So I tend a little towards the lower end of the spectrum, thinking that potentially then we just have less physiologic consequences of the pneumoperitoneum, so the 12-ish range. But I can't say that I purposely try to turn it any lower than that, unless we just clearly have enough space at that stage.
Yeah, honestly, it's not something I think about very often. I just put it at 15, and I only lower it if the anesthesiologist asks me to.
That's a great question, Adrian. I have a partner who actually is very interested in low pneumoperitoneum surgery. There is pretty good data showing that stretch on the visceral nerves in the abdominal wall, perhaps, and that's why I do my tap block. I'll put in 1 or 2 ports, do my tap block, and then put in the rest of my ports, thinking we're mitigating some of that. But he's found some pretty interesting findings. His patients require fewer pain medications. Even in the ERAS, we're trying to do no opioid surgery and no opioids post-op. And his patients do really well. He's started doing this with gallbladders, but it will be interesting to see where it goes. Oh, I think you're still muted, Adrian.
Any other questions you have queued up, Kunoor?
I think that's it.
Great. Well, I can't thank you guys enough, both you, Farah and Stacy, for taking the time and your and sharing your expertise with our audience and our fellows. And we look forward to the Q&A this afternoon for the West Coast session. And also we look forward to having you back on our program in the future. Thank you so much, everyone.
Thanks, Adrian.
Thank you.
All right. Well, those were 2 great talks. Welcome, everyone, to the afternoon session. I'm Matt Martin. I'm here with my co-moderator, Dr. Julianne Lloyd. And I see Dr. Farah Husain. Farah, can you hear us?
I can hear you. Can you guys hear me okay?
Yes, and I don't see Dr. Brethauer, so you have to defend both positions now. We only have a few minutes for questions, so let's jump right into a couple. So Dr. Husain, smoking cessation and testing. what is your policy? How long do they have to have ceased smoking? Are you doing the cotinine test? And what do you do with the patient who they're a clear candidate for bariatric surgery and they keep coming in month after month and saying, I'm down to 1 cigarette a day, 2 cigarettes a day, but I just can't stop?
We generally require 3 months of smoking cessation prior to surgery. Why we chose 3 months, I don't know, just kind of out of the air. I think like a lot of the things we do, there may not be the best evidence to support that. We know that from the anesthesia risk, at least having several weeks of nicotine free is probably good. We talk to the patients pretty in depth about their choice of surgery, whether they're electing for a bypass versus sleeve, understanding that perhaps it's going to be safer to do the sleeve long term, and see if that might be an option if they're really struggling. We do use nicotine replacements in our program, and I think that can be a nice way to help them with smoking cessation rather than expecting patients to just stop cold turkey or be able to do it completely on their own. And our psychology team actually works with them pretty intensively as well. We'd have to check a serum cotinine or a urine tox on a lot of our patients based on insurance requirements. So we tend to check them if their insurance requires it ahead of time. We do one about 2 to 3 months prior to their surgery date, and we don't repeat them on the day of surgery unless there's a high index of suspicion or concern in a bypass patient. But it takes 7 days for the cotinine to clear if they're using a replacement. And since we do allow their replacements, it's not really that useful in our practice.
And so what are you doing with that patient who's, I still smoke 1 to 2 cigarettes a day and, just can't quit, but I really need bariatric surgery?
Yeah, I mean, in our group, I'm the pushover, and every patient seems to know it, quite honestly. So I'll sleeve them if they are still smoking and they've otherwise really been compliant with the program and stuck with it. The ones that keep coming back and are still smoking are usually following up with our support groups, doing other things that show that they're pretty dedicated to the program. And I don't know that punitively they should be completely disqualified because of that. Again, we try to, at least even for a couple weeks, see if we can get them off of the cigarettes just to lessen the anesthetic risk as well.
Sure. Okay.
That was excellent, Dr. Husain. I have another question about your presentation. So you had mentioned that there are certain patients that you'll send to do upper endoscopy. You're more of a selective endoscopy approach. How extensive is your evaluation into symptomatic patients who have GERD? Like, what kind of testing are you offering to them in addition to the endoscopy?
Great question. Again, this tends to come down to what procedure they're opting for more than anything else. If patients are really quite insistent that they'd like to have a sleeve gastrectomy despite having GERD, we do try to get into the symptomatology. What do they complain of the most? How well controlled are their symptoms on their PPI? And I do tend to then order a pH study as well as impedance manometry on those folks, because I do worry about what the tail end will really show. This is totally my bias. In my older female patients, I also have a shorter leash to order manometry to look at their esophageal function, because I've just, again, anecdotally found that some of them have some esophageal dysmotility at baseline that they've really compensated well for. And once you start to do things to their stomach, they don't compensate nearly as well. But I don't have a really clear demographic. I just tend to say my older female patients on that.
All right. There's a question about the substance abuse and suicidal ideation or attempts issue. I think that's another thing, kind of like smoking, of where you draw your cutoff. So do you have any set policy on, for patients who have substance abuse, how long they have to be documented off of the whatever illicit substance? And then same thing with the patients who have had a prior suicide attempt or admission for suicide attempt. How long from that event do you require before you will proceed with bariatric surgery?
We're generally guided in this area by our mental health experts, quite honestly, because I don't think there's a lot in the literature that tells you an exact amount of time with either of those risk factors. Obviously, you want them free of substance and abuse, in a good program, and having good support structures in place. Our general rule is a minimum of 6 months out from both of those events. But we can flex on that a little bit if our mental health providers feel like there is good optimization or if they need a longer duration of time. I think both of those are really, really challenging areas because there isn't a clear-cut guideline that says you should wait this time and you're going to have less risk of, relapse in either areas after surgery. So quite often the issues that led to them preoperatively may still be present in those patients' lives. So optimizing them is going to be very important, and trying to encourage them to have ongoing counseling afterwards. I do tell my fellows our number one no-show or cancellation in the early postoperative period are our psych follow-ups. Patients, for whatever reason, they're on that euphoric high. I think after surgery, they don't show for hardly any of our psychology follow-up appointments. And I think that's really, really problematic because long-term, that's probably something they need more than almost anything else. So if there was some way we could get them to know, hey, this is probably very important for your follow-up because your support structures aren't going to evolve that much from pre to post-op, and you likely will need that ongoing care.
So I have a follow-up question for that too, because I wanted to ask you specifically about your post-op follow-up for psychiatry patients, or psychology follow-up, because we typically had not been doing that during my training. When do you normally have the patients come in?
So we always offer a 1 month and 3 month visit to our patients with our psychology team. Again, our 1 months were being just blown off pretty much almost at a 90% rate. So we've made that an optional visit now for patients to schedule when they do their first post-op with us at around 1 to 2 weeks. And then we ask them if they want to. We do schedule a 3 month for everyone to see if at that point, maybe they are slowing down on their weight loss and realizing some of life's stressors. And then we try to offer an annual follow-up thereafter as well. If we could do more, I think we would offer more because I think that 3 month does catch some of those folks that are starting to head down a slippery slope and need some added support.
Okay, just really quickly, there's one question in the chat from Dr. Guzman. He's asking whether or not you disqualify patients just based on the fact that they've gained weight in the preoperative period. What's your policy?
So this is going to be thematic today. I am, again, the pushover. I do not disqualify people because they've gained weight, especially in the last year and a half. I think COVID has added a whole nother stressor to people. A lot of folks have had a lot of challenges with weight gain when they've been quarantined at home, when their gyms have been closed, they haven't been able to maintain their normal routine. But even outside of COVID, I think a lot of it has to do with, are they otherwise doing the right things? Are they coming to their appointments? Are they actively involved in their care? I think the weight measure is just one small window into what's happening in people's health. And I really think obesity, it's a disease. I think it can be very resistant and very hard for patients to maintain their weight loss. And so if we see weights going up, we don't just tell people also exercise more, eat less, because I think we all know that dogma is not the right thing to follow. But we ask them about medication interventions. Should we start phentermine? Should we work with them more intensively? We offer more intensive prehabilitation just to help their functional status. So they may end up meeting with our physical therapist weekly and working on functional status. And so I think, again, it's the whole patient and making sure they're otherwise optimized and realizing that the number is something you have to take with a grain of salt. If they're up 5 pounds, is that really a reason to punish them from not having surgery versus if they're up 50 pounds? Okay, you have a red flag there. Something's going on that you need to address before surgery. So again, looking at the whole patient and not just one variable, I think is really important because also remember, insurance is kind of trying to run our game. If we start punishing patients for every pound they gain, then you can guarantee they're going to latch onto that in the notes and say, oh, well, maybe we need to go back to requiring a percentage of total body weight loss before your surgery. And I just caution people. I mean, we're losing enough in clinical medicine. I don't really want to lose the ability to make a judgment call based on knowing my patients.
Yeah, that's a great point. Okay, unfortunately, we're out of time. Those are two great talks. We really want to thank Dr. Husain and also Dr. Brethauer. Thanks to my co-moderator, Dr. Lloyd, and Dr. Dan, and we will sign off and see everyone next month. Thanks, everyone.
Thank you.
All right, thank you.